get those who are interested in the rare neuroimmune disorders and provide them with additional training and access to the experts and start putting them out, getting them out across the country. Some of them seem to stay in Texas for some reason, but we're working on it. So we have Dr. Michael Sweeney, Dr. Cynthia Wing, Dr. Kyle Blackburn, and Dr. Jonathan Galley, who are here. And we're just going to start off, if you guys want to kind of take turns and give us an update as far as your research and clinical experience goes, and those questions we were asking you earlier to hang on to for a bit. Once they're done with our updates, we can start with those questions, and if they need to throw them out to any of the other individuals in the audience, I think we can do that as well. So go ahead and get us started.
You want me to start?
Sure.
All right, so I'm Mike Sweeney. I am a child neurologist, and I did my residency training at Cincinnati Children's Hospital in Cincinnati, and then I did my fellowship in autoimmune neurology at the University of Utah with Stacy Clardy, and I spent a little bit of time in Texas with Dr. Greenberg, and I now practice at the University of Louisville and Norton Children's Hospital in Louisville, Kentucky. I see children the majority of my time, and I see adults 1 day a week. I primarily see people with autoimmune neurologic disorders that run the gamut, and I do a little bit of general pediatric neurology as well. Most of my time so far in Kentucky has been based on setting up a clinic and establishing a network there. We're going to be a site for the upcoming AFM natural history study and some other MOG initiatives there as well.
I'm Cynthia Wing. I graduated from UT Southwestern for my medical school. Then I went out to University of Michigan, Ann Arbor for my pediatric neurology residency, and then I came back to Texas to do fellowship with Dr. Greenberg. So I have now sort of stayed on as a faculty member to do more ADEM and brain-related rare neuroimmune disorders, so kind of setting up a autoimmune encephalitis clinic there. Yeah, so I think starting that up, seeing children with ADEM as well as other types of, possibly autoimmune brain conditions has been really rewarding. I'm still running an aperture study, which is kind of like capture for ADEM, so if anybody's interested, it's a longitudinal study seeing how people are doing in quality of life and physical condition and neurocognitive functioning after their ADEM.
And I'm Kyle Blackburn. I actually grew up not too far from here in Kentucky, and then moved to Texas for my residency. So I went to UT Southwestern for residency, interacted with Dr. Greenberg there, and decided that I was going to stay on for fellowship. So I've been training for the last 2 years, studying adult and pediatric neuroimmune disorders. All things likely, I'm going to stay on the faculty. I married into Texas, and my wife is really struggling to let me leave. So I'm going to wind up at UT Southwestern as faculty, probably primarily focusing on the adult side, and I plan to see the full gamut of neuroimmune disorders. And then in terms of research, we've been working on launching a project for some time, and we're really starting to get it launched. Many of you in the room may have heard about the CAPTURE study or gotten updates on CAPTURE as you came to the symposia over the years. From CAPTURE, we've kind of decided to expand the kind of the inclusion criteria of that study to include not only children but adults with TM or AFM, and to open up the time limit. If you remember, CAPTURE had a time limit of within 6 months of onset. So we decided to launch a study. We've called it Core TM. And we're actually recruiting for that across the United States, trying to ambitiously get the experience of 1,000 patients with transverse myelitis or AFM. So we can get you more information about that afterward if you're interested.
And I'm Jonathan Galley. I did my residency at the University of Utah. I actually met the Dr. Sweeney when I was budding intern there. And now I'm still a fellow there trying to fill his shoes where my research mentor, also Dr. Clardy, reminds me that he was her favorite fellow. I do plan on staying on staff at the University of Utah. I didn't marry into Salt Lake, but I think if I tried to move us now, my wife would probably murder me. So I love Salt Lake, so I'll be staying there. And really, as part of my staying there, I want to really try to expand the influence of the TMA in our area and also get some of our patients more involved and link them up with resources. I am adult neurology trained, so I'll be seeing primarily adult patients, but I also want to be kind of our point person in the transition from pediatric patients once they hit 18 from the Intermountain healthcare system into the university system. I think a lot of those patients kind of get lost, so I want to try to coordinate that a little bit more. And then I see a lot of NMO and MOG right now in my clinic that's just starting. It just happens to be what's been coming through. So from a research standpoint, my project that is finally getting off the ground is kind of a two-part project. So we have a really unique relationship with the Department of Defense and the VA being in Salt Lake. So what we did is we looked at several different databases of patients with NMO, including we did several different chart reviews and pulled patients from several different chart review projects. But what we're doing is we're doing an epidemiological study on patients nationwide with NMO within the VA and Department of Defense system. I still have to crunch those numbers, but we finally finished that part up. And then the second half, which is I think the really exciting part, is we're actually able to get serum samples on a lot of these patients, which we just requested. And so what we're going to do is get those samples and then actually have Mayo run testing and look at the aquaporin 4 antibody at time of diagnosis, about a year before diagnosis, and then a couple other time points after to really see what the natural history of the antibody is. So we're really excited about that, and we have some other markers we're going to check. So we'll see. I think we're actually going to hopefully have most of that data by the time fellowship comes to an end, but we'll see.
All right, so I think we get to open it up for questions.
Yes, okay. I just wanted to say, if you ever need a year off America, Australia's a great place. So come on down.
Yeah, so any questions of the fellows, their research, or anything from earlier today too?
Looks like the sun.
It's just
like sunset.
I guess you guys can try to answer this if you'd like. It's more so for the neurogenic bladder. I was just wondering, because I see a pattern in myself, is there any kind of connection between anxiety and increased like urgency, urination, accidents? I found that, to be blunt, whenever I am in an anxious situation, it gets a lot worse, and I'm trying to manage it, but any help would be appreciated.
So yes, there is a correlation. When you're anxious, you have a sympathetic surge. And there is this condition called the detrusor sphincter dyssynergia, which is incongruence into how the sphincter and the detrusor muscle, which is the bladder muscle, works. When you have a spinal disease-related neurogenic bladder versus traumatic brain injury or stroke one, there is this additional, not only that you have hyperreflexia of the detrusor of the bladder muscle, but you have this incongruence in between when the detrusor contracts and the sphincter contracts. Now the sphincter has a lot of sympathetic influence. So there is this work. They both contract in the same time, and something's about to give. So, DSD.
Do you find that, like with TM and NMO, I have NMO, but I had a cold, for instance, last year. And when I got a cold, then I'm terrified because I'm thinking, am I going to have another attack? Because a lot of the attacks, they said, were precipitated. The acute phase was, somebody was ill or somebody had the flu. Do you find that with people who have TM or NMO or any of these AFM, that if they get sick, now they have an attack?
So I think just speaking to the true idiopathic TM, we do see that there seems to be a set-off event in many people, or at least that's what we think, where they have some sort of viral illness, but that's not present in all people. And we don't see that moving down the road after someone has had their initial event of transverse myelitis, that additional episodes of viral infections set off another cascade of inflammation. In diseases that are driven by different processes like NMO, I don't know of an association between acute illness and risk of attack. And I'm trying to think across other autoimmune diseases as well. I'm not familiar with any literature that would support that, and I haven't seen that in my own experience.
Yeah, I would agree. I think we have our great nurse Denise, so she always takes these calls. But the first things we always ask is, if you're having the symptoms of the illness, could the illness itself be sort of unmasking some of your old symptoms, a pseudo exacerbation or a pseudo flare? So we do take some stock in that. It has to last a certain amount of time before we would really go to like imaging or spinal fluid studies to confirm a new attack. So I think if you can identify, infection, heat, something that could be exacerbating things, trying to remove that, and then seeing if the symptoms calm down. If it's old symptoms, then I think it could be in fitting with a pseudo exacerbation. But for instance, if you had optic neuritis in your right eye and then you're having blurry vision and pain in your left eye, that's a pretty good red flag that it could be a new attack.
Oh, hi. My name is Kim. My son, Jordan, has had transverse myelitis since October 2011. He's total care, dependent on a power chair, minimal use of his right forearm. He has a suprapubic catheter, and I do his bowel care and everything. My question is, my urologist, or his urologist, we go back and forth about the suprapubic catheter and then him someday needing to have an ileal conduit. And I know that's a pretty big surgery. At what point do I give into that? I mean, I just feel like it's I don't want him to just, how do you say, have a surgery.
Has recurrent urinary tract infections that keep him from going to school or doing all the social activities or putting him into the hospital, or if he has no bladder storage capacity, that bladder compliance decreased to the point in which basically it only accommodates that suprapubic balloon, the catheter balloon, then probably it's time to. But otherwise, the longest you can.
He's only had one infection, septic one time out of 8 years.
Okay.
So I keep fighting the doctor, but I'm like,
Can always,
not broke,
yeah. And if it's not broke, don't fix it. You can always get another neurourologist.
Second opinions are encouraged. Yes.
Dr. Wang, you mentioned waiting a certain amount of time after removing yourself from the heat or whatever stressor it could be. I know in our experience, my husband has MOG. Time is really of the essence, and so we something might happen and we're alert, we have to act because the longer that we've waited in the past, the much more time it takes to recover. So when you say wait, what exactly do you mean? Like 10 minutes? Like 10 hours? Like,
Right, I think part of, after you've had the illness is sort of knowing where your new normal is, and I think people probably do have an intuitive idea of like, oh, this is numbness, that's a little bit worse than before, but it's fluctuating versus, again, the things I would expect would be just, continued progression of symptoms without any, plateauing or any improvement. And, sometimes we'll use that 24-hour mark, but that by no means means that you shouldn't be contacting your physicians just to let them know so that they're aware. They can start by ordering some tests to also help answer that question. So, yeah, I definitely see sort of the paradox of saying that when many people in this room, they've had courses where they went from normal to not normal, in much less than that time. But yeah, I think once you have a diagnosis, you're at risk for relapse. I think with some people, we will not necessarily always have steroids on hand, but we know that's your plan. If you have an attack, you're really concerned about it, then you get to do a high-dose steroid course, because probably there is more harm in letting it go untreated than having some extra steroids for 3 days. So I think you bring up a good point. It's about balance. We don't want to overtreat, but I think during that initial period where you're still getting to know your body after an illness, it's certainly better to be on the side of caution.
We really need 2 microphones.
This is a very simple, basic question. So what's the difference between a pseudo flare and a flare? Is that, I understand that there's the relapse, but are we saying there's a pseudo flare and a flare?
Yeah, I think I use them interchangeably: relapse, attack, exacerbation, flare. So I think basically the distinguishing features, if there is evidence of new inflammation in the central nervous system. So some ways we get at that is looking for new lesions on MRI brain, or a pattern in the spinal fluid that might support too many immune cells. Usually flares will last days, upwards of weeks. And they would respond to steroids, whereas a pseudo-exacerbation should not necessarily respond to steroids, because it's more the body maybe temporarily not compensating well enough, because with the deficits that people gain from these illnesses, your body's working 110%. So when you have an illness, when it's 100, still like 105 degrees in Dallas right now, your body sometimes just can't keep those symptoms under the surface.
Any more questions?
I don't want to hog the questions. but, I find that with the NMO, it's like throughout the day, it's different. Like in the morning, it's, more clear than throughout the day. Are there any ophthalmologists or people who specialize in, you go, you have an eye exam, and it's, real quick. They say, okay, look through here, look through there. Well, the problem is, 2 hours from then, those aren't going to work anymore. Is there anybody who specializes in, okay, you've got this rare thing, so we either have to get you 3 different pairs of glasses, or they need to develop a glass that you can adjust yourself throughout the day as your vision changes. But
A reactive lens.
so it's frustrating, because maybe I can read in the morning, but then in the evening not. But if I adjust even if I hold my glasses funny, sometimes I can see better. So is there anybody who you can find or go to that will deal with that?
That is a quite complicated question. I think, we see that pattern of progression throughout the day in many neurologic autoimmune diseases, where maybe when you wake up, you're full of energy and you're at your best. And as the day goes on, some of that wanes. And for you, it could be that some of the muscles that control this, some of the nerves that control the small muscles in your eye may be affected, and that could affect your visual acuity as the day goes on. I don't know of a specific way to combat that. The person to ask would be a neuro-ophthalmologist that's versed in autoimmune diseases, but that would be a hard person to find. Dr. Pardo, do you know any ideas for that one?
That question is very interesting, because if you had evidence of optic nerve damage in the past associated with NMO, it's very likely that the cell that is in your retina that is called retinal ganglion cell has been affected. And there is then a possibility that environmental changes are going to affect your visual acuity. For example, if you are outdoors in a beautiful afternoon in Columbus, your vision is going to be very good. But if you are in this environment, your vision may be decreased. And that is because the damage of the optic nerve affected the ganglion cell layer, the retina neurons, and that is decreasing the threshold for capture of the visual information. So the neuro-ophthalmologist who is seeing you may do an assessment in a normal light and say, well, your vision is 20/20. But if he does an assessment or she does an assessment in dark environment, your visual acuity may decrease dramatically. So environmental changes in patients with optic nerve disease definitely will affect your vision. And that is related with the amount of light and brightness that is available. But it's related also with the residual change and damage that is left in your retina. We use a technique that is called optic coherence tomography, that is to actually measure the retinal ganglion cells and the retinal nerve fibers to see what is the magnitude of that damage. And based on that, your neuro-ophthalmologist may predict what is the best intervention. But technically, that is related with environmental changes and brightness.
Yeah, and I think to that point, you can make things easier for yourself if you keep things better lit. If I don't know, with like tablets now, you can increase the size of the print. Anything that you can do to bring out contrast in what you're seeing, I think will help with your vision.
There's a neuro-ophthalmologist at UT Southwestern, Dr. Hogan, and he was the one that actually found that there was something going on in my brainstem. I was seeing Dr. Greenberg, he sent me to him, and he helped in the diagnosis. So if you get a good neuro-ophthalmologist, a lot of times they can pick up on what's going on. But he's a good resource for you.
I was just wondering if you guys have ever seen any liver involvement after a first-time NMO attack. Once the patient's been stabilized, if there's ever been incidents of liver enzymes skyrocketing and jaundice and all that.
Are you talking about just NMO before any treatments, or is this after medications have been given?
So after 5 solumedrols and stabilized, no Rituxan. I wasn't stable to have Rituxan yet. My liver began to fail.
Yeah, so you can have transient elevations of your liver enzymes after high-dose steroids. Also, with a number of the other medicines we use more for chronic treatment, we can see rises in liver enzymes. But in the acute phase, you can see that with high-dose steroids.
Does that happen pretty quickly, or is it something that, like a month later?
I would think it's usually pretty quickly, like within that treatment period.
Okay. What condition did you say?
NMO.
NMO. I know that since it goes along with other autoimmune illnesses, it could be a separate autoimmune, liver condition. So, yeah, if that's a trend that's not, independent of the medication, then that might be something worth looking into with a gastroenterologist.
It completely resolved on its own before they hospitalized me.
Oh, that's
So it was, I just didn't know if there was, I've asked before at other like patient days and stuff, and no one's ever seen a correlation or had that before, so I was just looking for another cause of it.
Yeah. So endogenous steroids that your body makes, they're metabolized in the liver, and when we give the body's not used to getting that high of a dose,
Right.
and when we overload, some people are sensitive to that.
Okay, thank
Yeah.
you.
Mhm.
Hi. My question is, so my daughter, who's 5, we straight cath her multiple times a day, 5 to 6 times a day, and she's constantly leaking. Today's the first time that I had ever heard of the Botox injection in the bladder. Is this something common in children? Is it something, I've never even heard of it from my urologist, her urologist.
Dr. Stas, you want to take it, or you want to?
Yeah, I feel like you have more experience.
Yeah. Honorary fellow, Dr. Stas.
So, is it common? No, but does it happen? Yes. So, Botox is approved for usage in children, in pediatric population, both for spasticity management and for neurogenic bladder.
So I will say kids tend to need to be sedated for the procedure, especially at that age, and you're looking at every 2 to 3 months, sometimes
bladder,
longer. Yeah.
Yeah, for bladder it could be up to 6 months.
Yeah. But it does work pretty well for some people in the right setting, so it's something to consider. Exactly. Yeah.
And in fact, if she gets Botox for her legs, the timing of the Botox for the legs needs to be similar to the one for the bladder, because Botox is an organic product that creates and could potentially create antibodies. Definitely creates antibodies, but some of them could be neutralizing antibodies, so it could decrease the efficacy. They should be.
I just wanted to expand on that a little bit with my son's personal experience. We do Botox to the bladder every 6 months, and I actually wrote a chapter in Sandy's book about it, and for my son, it was a game changer for him. I didn't realize how much it would be, and I put it off for a long time because it was scary to me, but we did it, and it gives him an independence and a confidence that I didn't know that he had the capability of having, I guess. And we started every 6 months, and it was like on the dot, 6 months, we needed to get back in there. And as he's gone through the years, it does seem to wear off a little quicker, but it has been effective for him, and it's been incredible. But I know I was incredibly scared about it. The whole idea of it did not sit well with me, but we were kind of at our wits' end with medications, and he's self-cathing, and it really has changed a lot for him. So. Oh, he's 12, and we started, oh goodness, it seems like so long ago. We started doing that, I think, when he was 8 years old. And it's just finding the right pediatric urologist that understands neurogenic bladder, and then making sure to do the tests ahead of time. I asked for a lot of data because I really wanted to be sure I wanted to be comfortable with the right decision. So, and yeah, we do. We actually go in as outpatient into the hospital. He is sedated. He also has breathing issues, so we have to do more than sedation. He goes under general anesthesia, but it's an outpatient procedure. We have not had any complications, and it goes pretty well, pretty seamless.
Any more questions?